Hi, it's Josh Guttman from POCUS. Today we're going to talk about point-of-care ultrasound and cardiac arrest, the why, when, how, and who. So with these four questions, you're going to discover how to use point-of-care ultrasound in cardiac arrest. Point-of-care ultrasound has been used in cardiac arrest for a fair amount of time now, initially used just to prognosticate who will more likely have return of spontaneous circulation with survival to hospital discharge neurologically intact, and who won't, but it's progressed since then. And in this lecture, you'll get the nuts and bolts on when and how and who and all those questions of how to incorporate it into your practice on your next shift or your next patient with cardiac arrest. So, why would we do it? That's the first question. So, first is to treat reversible causes, which we'll go through in a sec. Next is to diagnose cardiac arrest. And so sometimes you may not be sure if someone's in cardiac arrest or not. And so you can help diagnose that. Third, prognosticate, as I just mentioned. And fourth, and some special procedural guidance. Let's look at the potential reversible causes. We all know our H's and T's, and so ultrasound can help in some of those H's and some T's. So first, there's tamponade. Second, there's tension pneumothorax. Third is thrombus or PE. Here's an image of DVT. In cardiac arrest, the right ventricle tends to dilate, so that dilated right ventricle might not be as helpful, but certainly finding a DVT would suggest that PE might be a cause. Next is hypovolemia. This is a picture of a fully collapsing IVC, which suggests hypovolemia or hemorrhage. And lastly, we have hemorrhage, and this is a fast exam with free fluid in the abdomen. And so those some T's or some H's or some reversible causes that can be looked at in cardiac arrest. And so ultrasound is really your best way to diagnose these at the bedside, especially without any previous information. Next, I'm going to talk about POCUS pulse checks. So the literature is actually pretty good on this, in that pulse checks with our hands, especially with larger patients, larger necks, more obese patients, we're not that good at actually detecting a pulse with our fingers. And what ultrasound can do is ultrasound can then actually do a pulse check and actually look at the artery and see if there's any pulsations, actually look for a pulse. And so this is what it would look like on ultrasound when looking at the carotid artery. And in the blue, just below, is the carotid artery. Here's the internal jugular above. And I put this picture on purpose because don't be fooled by the color. If you're early in ultrasound, you might think, okay, the artery is going to be red and the vein is going to be blue, but the color actually depends on the direction of flow. Flow towards the ultrasound probe is red and flow away is blue. So don't worry about the color. But if you look at the carotid below, you can see that it pulsates. So not only does it have color flowing through it, does have flow that's flowing through it, but also you can see its pulsations. And so a good question that you might ask is, how do I know what, from a pulsation standpoint, what's considered to be equivalent of a pulse with my hand? And that exact detail has not really been borne out yet. But today, what you're really looking for is that active pulsation. So even if you're not using color, if you can see the artery physically pulsate, then that is considered to be a POCUS equivalent of a pulse, especially if it's someone who's obese, who you might not know, hey, am I getting a pulse? Am I not getting a pulse? Am I feeling it? Am I not feeling it? If you have actually these active pulsations, you can consider them to be having a pulse. So this person here who has this would certainly have a pulse. So this is a good move to use when you're trying to do pulse checks. Now, the caveat that I will tell you is, in my experience, if you're in the middle of a cardiac arrest and you've just given some epinephrine, then you might get this bolus of color that goes through the artery. And that bolus of color doesn't necessarily mean that there's actual flow and there's actual pulse. And so if you've just given an epinephrine and you've got your probe on the patient, you might want to wait a minute or two and assume they're pulseless before assuming that that flow that goes through the artery is in fact due to return of spontaneous circulation. So try to do this next time you have a cardiac arrest and see what it looks like. Next is differentiating PEA and pseudo-PEA. And I think this first appeared in the ACLS guidelines, I believe is in 2015. But the understanding that we all know PEA as pulseless electrical activity if we've taken ACLS or practice acute care medicine. And what PEA is there is an electrical activity through the heart that's relatively normal, but you don't have a pulse. And so the idea is that the heart is generally not pumping enough, or the thought is that the heart is not pumping enough to create a pulsation. But really, this is algorithmically looked at in ACLS, but really, PEA can be two things. It can be PEA, which is shown here on this side, which is there's no cardiac activity. And so the heart is actually not strong enough to pump out the blood in order to create a pulse. But then there's this concept of pseudo-PEA.
And this is pseudo PEA. If this person has no pulse, this heart is hyperdynamic. So the idea here is that the heart is not filled enough with volume. There's not enough volume in the heart to actually create a pulse. And so the treatments of these are very different. Whereas PEA should get epinephrine because the heart actually needs the inotropy. It needs a medication that's going to make the heart stronger. Pseudo PEA, this heart's already beating as fast as it can. Usually a pseudo PEA is due to a hemorrhage or hypovolemia. So this person needs fluid and blood and actually doesn't need epinephrine, and epinephrine can be harmful. And so this is really the main reason to differentiate PEA and pseudo PEA because their treatment algorithms are different. Next, this is an image from the POCUS Atlas. If you haven't checked it out, there's lots of cool ultrasound images on there. And what this is showing is VFib. So if you look carefully at the walls of this heart, you can see that they're fibrillating there. And so this is helpful when you're trying to differentiate asystole from fine VFib. Fine VFib is very fast ventricular fibrillation. And sometimes if you don't look carefully enough, it could look like asystole. But if you look at the heart, you can see that it's obviously fibrillating. So this is something that you would shock. You don't find this much on ultrasound because it's not that common to have this fine VFib. But if you see something like that, know that this ultrasound actually can sometimes be better than the rhythm on the cardiac monitor or the defibrillator machine in detecting ventricular fibrillation. The others I mentioned before is the prognostication. And so this is a heart. We can see here at the left ventricle that there's no cardiac activity inside of there. There's the right ventricle has just blood that's not moving very fast. It's sometimes referred to as smoke that's just swirling around in there. And this is a heart that's not moving. This is known as absent cardiac activity. And the thought is that if someone has no cardiac activity, they're less likely to have a meaningful return of spontaneous circulation with survival to hospital discharge neurologically intact. And that's the outcome that we tend to look for with cardiac arrest is we want them to live, but not only to live, but with some sort of decent neurological outcome. And so in the early days, when this was first being looked at, ultrasound and cardiac arrest, as I mentioned, it was really looked to prognosticate. And the initial studies showed that if someone had no cardiac activity, they were not going to have return of spontaneous circulation. So the recommendation at that time, and this was in the mid-2000s, was to stop your compressions and call it at that point. But as you can imagine, that's a self-fulfilling prophecy, meaning if you always stop compressions and you always stop resuscitation when there's no cardiac activity, obviously no one is going to survive because you stop resuscitating them. But what was found in subsequent larger studies is that while it is a good method of prognostication, that if someone's got absent cardiac activity, they're more likely to have a poor outcome. It's not absolute. And so what you need to do with this is take it into context with the rest of your clinical context. So if it was an unwitnessed cardiac arrest and someone older and sicker and they'd been down for a long time, then absent cardiac activity might say, hey, I can probably stop the resuscitation now because the resuscitation will be futile. But if this was a witnessed arrest, a young person, someone with potentially a good outcome, just because they don't have cardiac activity, well, that's certainly not a good sign. They're not doomed per se. You got to take this finding as a good prognosticator, but also just one element in the entire clinical context. Next, I'm going to talk about procedural guidance, and I want to talk specifically about intubation. And when intubating in cardiac arrest, the limitation you have with our end-tidal CO2 detector is that if there is very little circulating blood volume, such as in a patient in cardiac arrest, they may not circulate enough to the pulmonary circulation in order to make CO2. And so your end-tidal CO2, well, it should turn yellow when there's positive end-tidal CO2, and that's the most common way that we check for tracheal intubation. It might be purple, which indicates no end-tidal CO2, not because the tube is in the wrong place, but because they don't have enough end-tidal CO2 to actually be positive. In a case like cardiac arrest, if you think your tube is in the trachea, but you're not getting end-tidal CO2, it's possible that they're just not making end-tidal CO2. So you can use ultrasound in order to check to see if you're in the right place. This is how you do it. This image is from Life in the Fast Lane, their blog. And here's a trachea. So here the probe is on the patient's neck, the transverse plane. And what you'll see is normally you have the trachea is filled with air, and then the esophagus is right next to it. And here, this sort of air-filled bubble is the trachea. And if the tube is in the esophagus, you'll see a second bubble over here right next to the trachea. So if you're not seeing that extra bubble, then it's certainly in the trachea. If you're seeing something like this, then it should be removed and reintubated. And that's step number one. Step number two, this is also from Life in the Fast Lane, is you're looking to see if they have mainstem intubation or not. Is first you're going to look at lung sliding. And so if you've right mainstem intubated, there'll be no lung sliding on the left side, but sliding on the right side. Now, I will say sometimes you can get sliding in both, even with right mainstem intubation. But if there's no lung sliding on the left side after intubation, but there's sliding on the right side, then it is likely that you've right mainstem, assuming this person doesn't also have a pneumothorax. Next thing you're going to look at is for the diaphragm movement. So you're going to put the probe down where you look at the diaphragm, such as the FAST exam or when you're looking at a pleural effusion in the lungs, and you're going to see as the air is being insufflated from the bag, you should see the diaphragm move on both sides. So you're going to check that both sides. So you're going to look at lung sliding both sides, diaphragmatic excursion on both sides. And if you have those, then your tube is likely to be in the right place, but also not main-stemmed. All right. So when should we do it? And the reason we have to ask this question is because the main parts of cardiac arrest resuscitation is the chest compressions and the defibrillation. And so our ultrasound really shouldn't get in the way of those. And there's at least one good study that has shown that if there's no check placed on the ultrasound, then it could prolong pauses during pulse check. And so we want to make sure not to do that. So we want to interject the ultrasound in a way where it'll also not interrupt. So when do we do it? And so this is like kind of an ACLS algorithm with ultrasound kind of put in. And this is not a published algorithm. This is my algorithm and the way I do things when I'm running a cardiac arrest. So let's say we get into the pulse check and rhythm check, and we've done a POCUS pulse check if we feel like we needed to. Obviously, if they're in VFib and VTAC, we're not taking out the ultrasound, they're getting shocked. And so we're looking here at PEA and asystole. And so if we have a PEA or asystole, we're going to start compressions. During the first round of compressions, I'm preparing the ultrasound. So if the ultrasound is not in the room, I'm bringing it in. If I have a handheld, I'm preparing that. I'm putting the gel on the ultrasound, and I'm making sure it's ready to go for the next pulse check. We have our 2 minutes between pulse checks. During the first pulse check, I will check for cardiac contractility. So this is where I'm looking for PEA, pseudo PEA, and if there's cardiac activity or not. And that's what I'm looking for during this pulse check. Remember, each pulse check is 10 seconds. And so I'm only looking for one specific thing during each pulse check. Then I'm going back to compressions. During that next set of compressions, I'm looking for lung sliding because the chest compressions prevent me from looking at the heart, but they don't prevent me from looking at the lungs. So then I'm looking at lung sliding on each side to see if there is possibility that the tension pneumothorax might be causing the cardiac arrest. All right. Then as I'm doing this next pulse check, you'll intubate. If that's what you do, you can intubate at various stages. This talk is not talking about when to intubate, but you can certainly intubate at this stage. Next, during the pulse check and rhythm check, I'm going to look at the pericardium, and I'm looking for evidence of cardiac tamponade. And so I'm looking at one thing during that cardiac arrest. Then we're going back to our compressions, or 2 minutes of compressions. At this point, I'm looking for a DVT on the right. And you can look at a DVT on the left also if you have a clinical suspicion of DVT one way or another. But this is just a standard algorithm. Then during the next pulse check, I'm looking at the IVC. The IVC, I really need to not have cardiac compressions going on in order to look at the IVC. And then I'm looking for evidence of hypovolemia in order to know if I should give fluids. During the next set of compressions, I'm doing a DVT study on the other side. And then after that, we've already done 6-8 minutes of CPR. And so then I'm going to go check cardiac ultrasound contractility again to see where I am during the next pulse check and rhythm check. And then during the next set of compressions, I'm doing a FAST exam to look for hemorrhage. And so this algorithm is twofold. Is really using it during the pulse checks and rhythm checks, which are only 10 seconds, is to look at the heart or the IVC in one aspect. And during compressions, I'm doing an ultrasound, which can be done during compressions. And so something is being done during that time, really evaluating for the reversible causes and see if I can't find something that can be reversible and intervening at that point. Now, I gave a very rigid algorithm. In reality, if I think someone is more likely to have a DVT or their abdomen is distended and I think they might have a free fluid in the abdomen or intraperitoneal hemorrhage, I might do that first. I might go back and instead of doing a DVT first or instead of doing lung sliding first, I might look at the FAST exam first. And so you can take that clinical context into play. But at the end, I'm algorithmically doing everything to look everywhere for a cause of cardiac arrest, doing what I can do during compressions, so what needs to be done during a pause, such as looking at the heart or the IVC, I'm doing during that pause, only looking for one specific thing. How are we doing it? And the reason I have this mousetrap is because there's a lot of pitfalls. As I mentioned before, you don't want to prolong the pulse checks and prolong the pauses to do an ultrasound. That is ultimately worse for the patient. And so the focus is really, so how can we do the ultrasound successfully and get the information that we need while decreasing pauses in chest compressions. So back to the algorithm, here's some mechanisms that I use to do it. So with 10 seconds left before I'm going to the pulse check, rhythm check, the nurse or whoever is reading the code will say, there's 10 seconds left. I'm getting that ultrasound view. So I'm doing a subxiphoid view as if I'm trying to get the view right now. So I'm not doing that during the pause. So hopefully as soon as the chest compressions stop, the view will be right there and I'll have more time to look at the ultrasound. Next is with 15 seconds left. So even just before that, I'm making sure gel is on the transducer. So during those compressions and right before pulse check is going to happen, I make sure that the ultrasound is ready to go. And then I'm getting my subxiphoid so that as soon as the chest compressions stop, I'm not wasting time getting the view. I essentially already have the view ready to go. And so I have more time to look at my ultrasound. Next, during the pause, some tips that you can do to make sure you don't prolong pauses is first just get the clip. So especially if you're early on in ultrasound, don't try to get the image and interpret at the same time. Just focus on getting the image, save a clip, and then during the compression part of it, you can then interpret your image. So you're not trying to do too many things at the same time. So that's one way to do it. Another way is that if most of the time when you're saving clips on ultrasound, it'll save 6 seconds. And so we want to keep our pulse check pauses under 10 seconds. So if you press this is what I like to do. If I press the video clip button to save just as I'm starting, just as the pulse check and rhythm check start, and then I get my image, and then as soon as that clip stops recording, I stop doing the ultrasound, because then I've only done it for 6 seconds and I'm not prolonging the pulse checks. And then lastly, you can also just have the person who's running the code and timing just prompt you to tell you to get off the chest, and then you really have to get off the chest. And so if they say time to get off or 9 seconds, whatever your prompt is, you can't be like, okay, just one more second, I just almost got my view. Your hands off and you're continuing, and then you can always try again next time. So I had my algorithm say what to do with each one, but it doesn't mean if you didn't get your view and you didn't get the information you wanted, you can always do it again next time. And then you'll already know where to put the probe, and hopefully you'll be able to do it within the specified amount of time next time. But important is have someone prompt you to get off the chest so chest compressions can start and actually do it. Lastly is use the subxiphoid view. And if you think about it, when you're doing a parasternal long axis view on the chest, you're putting gel on the chest. And so if you're then asking someone to do compressions with gel on the chest, that can get a little slippery and make chest compressions not as effective. And so the subxiphoid view is really the best view for you to be able to see, because it's still relatively easy to get, and you can do it during compressions and get ready and not have gel on the chest in the way. If you can't get a subxiphoid view for some reason, if they have a lot of air in the abdomen and you're not able to get a good view, an apical 4-chamber is another option. But the idea is to use a view that's not going to interrupt the chest compressions, especially in the context of putting gel on where the chest compressions are going to happen. All right. And lastly, the who. So who should be doing the ultrasound? So you should have a designated sonologist. So what it means is someone's role in the cardiac arrest. It should not be the team leader. It should not be the person on the airway. But assuming you have enough people in the cardiac arrest, you should have someone whose job it is just to do the ultrasound, to follow through the algorithm that I was talking about. And their whole job is to do the ultrasound during compressions and during the pauses. And so really having that designated person relieves everyone else from being able to do that, and they can then feed back to the team leader the findings on ultrasound. And lastly is to have someone experienced. You don't want someone who's very inexperienced, some of their first few times, not that comfortable with ultrasound, because these things have to be done accurately and they have to be done quickly. So you want someone who's relatively experienced. So ideally you have the most experienced sonologist in the room. So for example, during a cardiac arrest, I have a lot of trainees with me. I have senior residents who are running the code as part of their training, and then I will do the ultrasound while they're running the code. It can be the other way around. If I'm running the code and I have a second year resident who's done a fair amount of ultrasound, they can be the ones to actually put the probe on the chest and be that designated sonologist. So you want someone with some experience, not someone who's new. Lastly, I just want to mention TEE as sort of the future. It's the present. There are emergency departments and ICUs that have TEE and are using it during cardiac arrest, but TEE really is in both the present and the future in cardiac arrest, and hopefully we can all have TEE in our departments. It's actually not that hard to do. You only need one type of view, but the TEE is advantageous in cardiac arrest, firstly because you can monitor the quality of the compression. So when you put the transesophageal ultrasound down the esophagus and you're looking at the heart, you can actually see that the compressions are compressing on the left ventricle and not on the outflow tract or something else. So you can monitor the quality, and you can help the person who's doing the chest compressions move their hand so that they're really pumping on the left ventricle. Second, it has a constant cardiac assessment. So instead of looking at the heart between compressions, You can look at the heart the entire time. The T is just better detail, so you have a nice, better view of the heart, especially if it's someone who has a difficult cardiac view. The T can usually get around that. And lastly, you have a more accurate VFib diagnosis. Remember, I had mentioned that VFib can be seen on ultrasound. Certainly, if you're looking at the heart better, you can see VFib in real time on the ultrasound. So generally, really, EE just gives you that really constant assessment of the heart during cardiac arrest. You don't have to worry about pauses, anything like that. You're constantly looking and seeing the change in real time. So it's really nice. So that's it on cardiac arrest. I hope you've enjoyed this talk. Feel free to reach out to me if you need any courses or have any questions related to ultrasound, point of care ultrasound. Love hearing from you all. And I hope that you take this lecture and apply it to your next cardiac arrest patient.